Good afternoon, everyone. My name is Jody West, and this is the Louisiana Provider to Provider Consultation Line Pediatric Mental Health Tele-Echo. Today is the 14th. We're going to go ahead and get started because it is noon. So I want to welcome everyone and just make some announcements. I am the coordinator for the ECHO series and as well as the program manager for the provider to provider consultation line. I'm going to run through some quick housekeeping items. If you can, please put your comments into the chat for us to address after our presentations. We're going to do brief introductions, and then Dr. Anna Brewer is going to lead us through the didactic presentation. And then Dr. Moore is going to do a case presentation, and we'll have time for clarifying questions from the group and participants, as well as recommendations, which will be sent out to all participants. And then we'll wrap up and discuss our next ECHO session in November, which will be our last for this series. So some brief introductions. I already mentioned I'm Jody West. I'm a social worker, and I help coordinate the ECHO sessions, and I'm the manager for the provider to provider consultation line. PPCL is a mental health consultation line focusing on pediatric as well as perinatal mental health concerns. So we provide services to providers that work with pediatric patients or clients, or perinatal patients or clients. And if there's a concern about mental health, you can reach out to us, and our team can either connect you to a psychiatrist if you have questions about medication or diagnosis, or we can also help you find resources and that's referral sources in your community or the patient's community, and get that information back to you to then share with your provider, with your patient. So we are support for you. Part of it is consultation, as well as these trainings that we provide in the ECHO series. This is the pediatric one, but we have a perinatal one as well. So if you scan that QR code or give us a call, you can get connected to the services that PPCL provides, and we can answer any questions you might have so that you can utilize us as a support for the work that you're doing in your community. Right now, I'm going to hand it over to Dr. Christine Olivier, and she is going to lead us in other introductions.
Hey, good afternoon, everybody. I'm Dr. Olivier. I'm a child and adolescent psychiatrist here in Lafayette, Louisiana, in private practice at Bloom Mental Wellness. I'm also the facilitator for these sessions, so I help manage the clock. Um, we are part of your hub team of experts who help facilitate these discussions. We have a variety of professions represented, including psychiatry, nursing, therapy, social work, and pediatrics. So with that said, I'm going to ask our pediatrician on our team to reintroduce herself, Dr. Cocky.
Hello, everybody. I'm Dr. Kelly Kalki, and I'm a private practice general pediatrician in Broussard, Louisiana. Welcome.
Thanks, Dr. Cocky. You already met Jody West. She's also one of our social workers. We also have another social worker on the team, Lena Ragat.
Hi, everybody. My name's Lena. I'm one of the mental health consultants for PPCL and also a member of the Hub team.
Thank you, Lena. And Ashley Hutchins, you want to reintroduce yourself, our nurse practitioner?
Hi, everybody. My name is Ashley Hutchins. I'm a psychiatric nurse practitioner at Bloom Mental Wellness in Lafayette, Louisiana.
All right. Thank you, Ashley. And I think that's everybody on the Hub team. Yes. Okay. All right. I'm going to turn it over to Dr. Brewer, who has graciously offered to do our didactic presentation today. So for the next 20 minutes, Dr. Brewer will talk about ADHD and PTSD in the young children population.
All right. Thanks so much for having me this morning. My background is definitely in infant mental health, but this is going to be a weird infant mental health presentation because I'm not going to have a lot of focus on the parent-child dyad. I'm going to be having us think more about trauma in young children, which always, of course, includes attachment figures. So today we're thinking about ADHD and PTSD and how they may intersect in young children. Oh, can you advance the slide? I'm trying to do it myself. All right, so we're going to consider how ADHD and PTSD may present for very young children in an outpatient mental health setting. We're going to compare symptoms and see places where ADHD and PTSD symptoms may look similar, places where they don't. We're going to use the DC 0 to 5 to help us with that, and I'll get into that in a moment, what that is. And then we're going to briefly consider next steps. Advance slide, please. Okay, so 20 minutes is not long. So I am not going to go into all of the research. And first of all, there just is not a lot. So I'm going to give you kind of the three main points that I found in doing some background on peer-reviewed literature. The first point is the one I've already made, which is that there is actually not very much research on the intersection of ADHD and PTSD across populations. There's almost none in young children, but even for older kiddos and adults, there's not a great deal out there. What does seem to be emerging from the current literature is that ADHD is a risk factor for the development of PTSD. But again, a lot more research needs to be done. Advanced slide, please. So when we think about the intersection of ADHD and ACEs, y'all are probably all familiar with ACEs, adverse childhood experiences, and these are the general ones listed right here. You can go ahead and advance slide, sorry. When we think about, we have a recent study from 2024 about ADHD and ACEs in children. And of course, the thing to remember about ACEs is that they are a traumatic experience, but they're not a diagnosis of PTSD. However, when you look at kiddos with ADHD compared to similar kiddos that do not have ADHD, you find that kiddos with ADHD have experienced more ACEs individually and more like a wider variety of ACEs than similarly matched peers. Okay, go ahead and advance the slide. All right, so let's talk about the DC 0 to 5. I'm going to use the criteria from the DC 0 to 5 today. If you're not familiar, the DC 0 to 5 is a diagnostic manual put out by the organization 0 to 3. And the reason I want to use it today and the reason it's so helpful is because it helps us think about how mental health symptoms and diagnoses may look somewhat different in very young children than they look in older kiddos or adults, obviously. Because so much is happening developmentally in this first 5 to 6 years of life. And behaviors that might be indicative of a symptom or something going on later in a child's life may just be developmentally normal during this time. And so the DC 0 to 5 does a nice job of helping us parse through some of those things. It also is always keeping in mind that attachment relationship or relationships that the child has with their caregivers. Brief version of attachment is simply that young children form bonds with caregivers. These bonds, the sun rises and sets on this caregiver. This bond is how they feel safe and okay in the world. It's how their needs are met. Young children start off seeking proximity to their caregivers because that is how they feel safe, loved, and their needs are met. And where this gets really important today is that when trauma happens to an attachment figure or with an attachment figure involved, that can also be traumatic to the young child. But anyway, the DC 0 to 5 does a nice job of like bringing in that piece, which the DSM is not focused on. Okay, go ahead and advance the slide. So what we're going to do is I'm going to go over some general stuff about PTSD and ADHD. Then we're going to go through the DC 0 to 5 criteria for inattentive cluster and hyperactive impulsive cluster for ADHD. And the reason I'm going to go through all of them is because then we're going to think a little bit about trauma and widening our scope on what might be traumatic to a young child. And then we're going to go through those PTSD criteria and see how sometimes there can be a similarity of presentation between PTSD and ADHD symptoms. Some are not similar at all, but there are some similarities sometimes. All right, so in the DC 0 to 5, with PTSD, obviously, we have to have exposure to trauma, and we'll talk more about what that might look like in a few minutes. Symptoms have to last more than 1 month, and this is a diagnosis to be used with caution in infants, kiddos under 12 months. Again, the DC 0 to 5 is looking at kiddos 0 to 5 or 6, so it's very focused. In the DC 0 to 5 with ADHD, a traumatic event has not necessarily occurred. Symptoms have to last greater than 6 months, and we're thinking about kiddos 36 months and older. This last one's really important. With ADHD, we are seeing the behaviors across environments. So this is happening at school, it's happening at home, it's happening at grandma's. This is behavior or symptoms that are happening kind of across the board generally, at least multiple environments. PTSD can look a little bit different, because what drives symptoms of PTSD are the trauma exposure or exposure to reminders of the trauma. And so this is a kiddo who might have a really safe, secure attachment with grandma. And so when she is with grandma, she is not showing dysregulation. But when she's back home, a place where domestic violence occurred, she might be much more dysregulated. Another important thing to note is that the DC 0 to 5 notes for us that symptoms or caregiver accommodations must cause impairment. So when we have young children, right, sometimes caregivers accommodate a lot for what's happening. And so if you've got a kiddo who, when you take them to the grocery store, is running around and screaming and pulling things off the shelves, you may just decide not to take them to the grocery store anymore. But that would represent a caregiver accommodation that might cause impairment in family functioning. Okay, advanced slide, please. All right. So let's look at inattentive type. Inattentive to details in play, activities of daily living, structured activities, hard time maintaining focus. This is the kiddo that is bouncing around from one thing to another, really struggling to get into either pretend play for an extended period of time. This is the kiddo that may also struggle with things like board games, Candyland. That may not be their thing. Fails to attend to verbal requests. This is our important reminder that symptoms are developmentally inappropriate for the child's age, because every 4-year-old fails to attend to verbal requests sometimes. So we are again comparing this child to their 4-year-old peers, or whatever age the child is, not to the way you would expect an older child to attend to verbal requests, for example. This kiddo may get derailed when attempting to follow multi-step instructions, may not complete activities. Oh, please advance the slide. I keep trying to do it myself, sorry. This kiddo may avoid activities that require sustained attention. So this child may have a really lovely relationship with their dad, and they are not going to sit in dad's lap and read a book together, because that is an activity that requires sustained attention. This kiddo may lose track of things that are important or used regularly, like their favorite stuffy. They can get distracted by sounds and sights. They can seem to forget what they're doing in common routines or activities. Again, this describes many 4-year-olds. We are comparing them to their peers. Advanced slide, please. All right, now when we're looking at hyperactivity, impulsivity, frequently squirms or fidgets when expected to be still. Every 3-year-old squirms and fidgets when expected to be still. So we're comparing to peers. This is a kiddo who's struggling with circle time, seat work, those kinds of things. May climb on furniture or other objects. Good old excessive motor activity, non-directed energy. This kiddo may talk more than other kiddos their age. Advanced slide. And then they may be noisier than other young children. Difficulty playing quietly. This is a kiddo that has difficulty with turn taking, both in conversation and also potentially in play. Turn taking in play is definitely a skill that is growing kind of across early childhood, but this is a kiddo who's having more challenges with that than their peers, and also may have challenges with waiting for needs to be met, and may be intrusive in play with others. All right, advanced slide. Okay, so now we're going to kind of shift our focus a little bit and think about trauma in young children. We need to kind of broaden our scope a little bit, as I said earlier, because things that impact the attachment figure can also be traumatic to the young child. Advanced slide, please. All right, so we've got our usual suspects here, right? Physical abuse, sexual, verbal abuse, physical neglect, car accidents, serious injuries. These are all obviously traumatic things that can occur for people of any age, including young children. Advanced slide, please. However, when the attachment figure is unavailable, harmed, or threatened, this can also be traumatic for the young child. So an important thing to think about is because the attachment figure or figures is how the child has that sense of security and things being okay in the world. When they have an extended separation from the attachment figure, that can create trauma for the young child if they're not sure what to do. And so this definitely includes kiddos who are taken into care in the child welfare system. They have been separated from an attachment figure. This can also occur, though, in other situations, such as a parent being incarcerated, extended hospitalizations, whether for a variety of reasons, the child is not getting to be with that caregiver. Loss of an attachment figure to death, and witnessing violence towards an attachment figure. There's been so much research about how domestic violence has some really difficult sequelae for some young children watching attachment figures harm each other or one attachment figure harm another attachment figure. Other types of violence, though, other types of family violence, community violence, just witnessing that violence towards the attachment figure. Advanced slide, please. Adverse caregiving environments. This is usually more, the first one is more for sometimes international adoptees, may have lived in an orphanage or group care setting. Frequent changes in caregivers. This can happen when a young child is in the child welfare system and they have been in several foster homes because they may make efforts to attach to one figure and then go to another figure, and so not have that steady sense of consistency. And then again, lack of consistent nurturing relationships. Advanced slide. Also, I am not going to go into this because we don't have enough time. I'm sorry. Natural disasters and frightening or invasive medical procedures. All right, advanced slide. Okay, so we're going to go through the symptoms of PTSD. Re-experiencing is play or behavior that may reenact some aspect of the trauma. Kiddos can be very active in their play. There can be a lot of energy or motor activity. They can be really noisy. And if we're not putting on our detective hat as adults to try and understand that play better, that can look like kind of the noisiness and activity of ADHD. Advanced slide. Re-experiencing can also include preoccupation with the traumatic events. This is a kiddo who's talking a lot about either the event itself or something connected to the event, or asking questions. They may not show distress at the time when they're asking these questions or talking. And so this may not necessarily look to the adult like it can look like excessive talking, right? If we've got a little guy who is talking about ambulances, asking questions about ambulances, we may think, oh my gosh, we were talking about ambulances. But for this little one, this may be, well, grandma was taken away by an ambulance and then was in the hospital for a long time. And so that might be some of that talking. Advanced slide. One that does not have a parallel is repeated nightmares. And just to note that they do not have to be related to the traumatic event in young children. It's just an uptick in nightmares. Advanced slide. All right, here we go. So significant distress at reminders of the traumatic event. So kiddos who have experienced trauma and have PTSD become dysregulated in one way or another, oftentimes when there are reminders. But again, sometimes as adults, we struggle to put together the pieces of what might be a reminder. Go ahead and advance the slide. Some re-experiencing things that don't really have parallels with ADHD symptoms are physiological reactions at reminders and dissociative episodes. Advanced slide. Okay, thinking about avoidance, the avoidance cluster for PTSD. The infant or young child persistently attempts to avoid trauma-related stimuli, including people, places, activities, conversations, interpersonal situations. So of course, young children don't always have a lot of power in terms of what they get to avoid, right? They're not like an adult who's just not going to go to that part of town or not going to go to that event. So sometimes how they show their avoidance is through motor activity and dysregulation. This could even look like running away. But sometimes we see that excessive motor activity around reminders. And so it's figuring out, is this about a reminder? And if so, what reminder is it? Advanced slide. All right, so loss of enjoyment, loss of interest is an area where we don't see parallels with ADHD. And so that can be helpful in our differential diagnosis because we're not seeing those things typically. So increased social withdrawal, reduced expression of positive emotions, lack of interest, and increased fearfulness or sadness. Advanced slide. All right, hyperarousal. With hyperarousal for young children, we see difficulty going to sleep, evidenced by strong bedtime protests. I love that phrase. While sleep concerns are not a diagnostic criteria for ADHD, they're frequently seen in children with ADHD. And so that can be a similarity we see there. Difficulty concentrating is found with hyperarousal and looks similar across disorders. Advanced slide. Hypervigilance is another symptom of hyperarousal. And hypervigilance is when the child is very focused on the environment. They are scanning for safety concerns. They may be scanning for something for a reminder or something along those lines. And so they are not paying attention to you. It can look like inattention. It can look like failure to respond to verbal requests, those kinds of things. One that does not have a parallel is exaggerated startle response. Next slide. Hyperarousal can also include increased irritability. And that can sometimes look similar as difficulty with waiting for needs to be met. It's that dysregulation that can look similar in terms of irritability across diagnoses. Advanced slide. So I think this is interesting. It's not actually in the DC 0 to 5, but in the DSM-5, we see reckless or self-endangering behavior as a symptom of PTSD. And I can tell you clinically and anecdotally that I feel like you see these kinds of behaviors quite a bit in young kiddos who've experienced trauma. And this can look like running away, but it can also look like climbing or other dangerous behaviors. And the climbing can often has a risk aspect to it, but it can look similar sometimes to the climbing that you can see in ADHD. All right, next slide. All right, so this is what the DC 0 to 5 says about ADHD and PTSD. PTSD may cause hyperarousal symptoms and distress that present as disorganized behaviors, but signs of PTSD should be linked to exposure or reminders of the potentially traumatic event. And this is where we as adults need to put our detective hats on and potentially definitely need to get a child psychotherapist involved because oftentimes we don't always initially see that connection between reminders, between exposure, and then between behavior. And so that's where that therapist can really help us start to understand that. Advanced slide. All right, so this is from the National Child Traumatic Stress Network. It's a great little graphic. They have a whole paper guide for clinicians on thinking about the intersection of trauma and ADHD, and that link will be in the slides. Advanced slide. All right, next steps. We have 15 seconds. So if you get nothing else from this presentation today, I hope that when you hear ADHD symptoms with young children, consider trauma. Do that thorough assessment. If that's not your wheelhouse, find a child mental health professional who can do that assessment and help us kind of start to suss out what's going on here. We definitely want to work closely with prescribers. I'm not a prescriber, so I'm not making any kind of comments around that, but we want to work closely with prescribers so we can be on the same page. And then if trauma has occurred and we think that that is driving some of these symptoms, we definitely want to refer to psychotherapy because that's going to help address some of those underlying issues that are driving some of these symptoms and behaviors. All right.
All right. Thank you, Dr. Brewer.